Hillary, I'm not able to start my video.
Can you see me?
Yes,
Great.
good. Okay. And now the opening slide. Welcome to Pilates Applications for Health Conditions. Madeline Black and I are delighted to welcome Dr. Diedra Manns. First, we'll have an opening slide that explains how the webinar will proceed. The chat will be on, so you're welcome and invited to welcome each other and correspond with each other. We also have the Q&A on, so please, during the session, mention your questions so that the last 10 to 15 minutes of the hour, Dr. Diedra Manns will answer them. The webinar will include some question and answer with discussion, presentations by Dr. Diedra Mann, and also a film clip of historic film in which Eve Gentry is working with Joseph Pilates during her breast cancer rehabilitation. Dr. Diedra Manns, who's Doctor of Physical Therapy, is the founder and CEO of Monarch Wellness Incorporated. She's a movement science fellow and a certified orthopedic manual therapist. Dr. Diedra is a national certified Pilates teacher and a Polestar educator. After her own journey with breast cancer, Dr. Diedra created Monarch Wellness, a boutique physical therapy, Pilates and wellness studio in Santa Monica, California. Dr. Diedra is the contributing author of the chapter on Pilates and breast cancer in the forthcoming book, Pilates Applications for Health Conditions, Case Reports and Perspectives, co-edited by Madeline Black and Elizabeth Larkam. Dr. Diedra Manns, welcome to Pilates Applications for Health Conditions.
Hello, everyone, and thank you so much for that lovely introduction, Elizabeth. I'm really honored to be here with both you and Madeline as these great founders of movement in our community, and also to just be with you guys in presenting this information to our community in general. So thank you for having me.
Yes. Diedra, would you tell us about your own journey with breast cancer?
Sure. I'm going to try to make this short, but I started off, I have a grandmother who had breast cancer, and she had a radical mastectomy in her 50s. And I just saw her, she was a nurse, and I saw her recover and improve her abilities through movement. I never saw her get herself down. She kept moving. She kept with her work. She kept moving herself forward. And I just looked at that in awe, you know, and just knew that she was such a great woman. Several years later, in my mid 30s, I found a lump in my own breast. I have fibrocystic breast disease, and I have been feeling myself up doing breast exams since I was 19 because of my grandmother's history, and just because that's just something that I had been taught. And so I was in my mid 30s when I felt a lump that didn't feel like the others that I have felt in the past. So I had it looked at, and long story short, the lump was cancerous. And so it was a very small lump, and it was taken out. And at that time that it was taken out, there was not this idea that I had. The person who took it out, the doctor at the time, she did not think that the lump was cancerous, but part of it did come back cancerous. And so we had to go back in and take larger margins, which means that they just had to take a little bit more tissue around where the original site of the tumor was. And I had a sentinel node biopsy done at that time. Everything came back fine after that. And I went through a series of a month-long series of radiation treatments, and I took tamoxifen as an endocrine therapy for 7 years after. And then I had been getting surveillance every year, which is great because that means that, you know, people are looking at me and looking at my breasts all the time. And there was something that was found, excuse me, in my axillary lymph node on my right side. And they attributed it to being the same cancer. It had the same cancer characteristics as the original cancer that I had, but now it had moved regionally into my lymph nodes underneath my arm, or in the axillary region. So I had to have 23 lymph nodes removed, and then went through chemotherapy. I'm grateful that I did not have to, that the cancer didn't spread anywhere else in my body. It was considered a regional metastasis. And so the outcomes have been great for me on that. So that was about 8 years ago now. And I'm just grateful to be here. And I say I'm on my third life now that I know of. So that's my story.
Yes. Deirdre, I know that I know you've been touring internationally. I see you frequently at Pilates on tours, giving presentations and educating the Pilates community, not only that way, but also through Polestar and making conference presentations there. In order to link your practices with your clients and with your patients in your studio, Madeline and I have prepared a video clip that shows Joseph Pilates working with Eve Gentry, and this will give some historic connection from the past to the present with your presentation.
Perfect.
Hillary, may we see the slide of Eve and also the credit slide? We may.
In theory.
Yes. Yes. There we go.
There we go.
Right. Great. Okay. Madeline, take it away. Madeline, would you like to give the introduction to Eve and the film? There we go.
Can you hear me?
Now we can. Perfect.
Okay. Something with the ear. These guys weren't. I was giving the introduction, so okay. Is one of our elder teachers, original teacher with Joseph Pilates. She was born in 1909 in San Bernardino, California. And in 1928, she moved to San Francisco to study modern dance. And then she moved to New York in 1936 to join the Hanya Home Dance Company. Hanya Home incorporated and had practiced with Joseph Pilates, and she used the mat work in her training of her dancers. So the connection between Hanya Home and Joseph Pilates was an important one for Eve meeting Mr. Pilates. Eve worked with Mr. Pilates from 1938 to 1968. In 1955, though, Eve was diagnosed and had a radical mastectomy and for breast cancer. And she turned to Joe for his help. So she had surgery, and you have to remember what they did in 1955, the kind of surgery. So they removed so much of her tissue She wasn't able to lift her arms up. So she returned to Joe for his help to rehabilitate herself, which they did. And Eve and Joe made an incredible video to show the medical community what Pilates did for her and how she restored her full movement. In fact, Eve returned to dancing full on 1 year after this surgery. So it was quite remarkable. They showed the film, and I'm gonna let Michelle speak the rest because there's some dialogue on the film. But Eve in 1968 moved to Santa Fe, where she connected with Michelle Larson and also Joan Breitbart and started the first institute for the Pilates method. But the institute started more like 1990, so not 1968, but that's where the beginning of the institute was. And then she died at the age of 84 on June 17th, 1994. So now we're going to show this clip, which is really given courtesy by Michelle Larson and Core Pilates Dynamics.
And at that point, he began to work with her on rehabilitation for a specific issue. So the story she tells is that there were doctors who were clients of Joe's at the time, and they were impressed by this rehabilitation, and they asked Joe to make a presentation to the board of the hospital. Bruce came into the studio and they did a film of Joseph Pilates teaching Eve, and they presented it to the hospital board. And Eve told me that the hospital board said, "We think it's a fake. Nobody who's had a radical mastectomy could do these moves, period. It's fake." So they went back into the studio, and Bruce took a film of Eve topless, doing the more specific rehab-y things. Not in the film where she's dressed, they're doing really a pretty standard Pilates workout. There's certain things in there that you wouldn't give to a standard client. But in the topless one, they're a little more specific to the radical mastectomy injury. So they took that film back to the hospital board, and they went, "Oh, okay. We'd be interested in Joseph Pilates coming to the hospital and establishing a curriculum for mastectomy patients." And then, this is Eve's quote, she said, "They discovered that Joe had no alphabet soup after his name, and they canceled the contract." She felt that this was very hurtful to Joe because he'd always wanted that recognition, and he didn't get it. She trusted Joe enough to go through that with him. It only took a year, though, and she regained full range of motion.
Deirdre, how do you see your work as being inspired and informed by these practices of Joseph Pilates, as well as informed by your PhD and your clinical experience?
So first, I want to say that, Joseph was fearless in the sense that there was this diagnosis, there was no tissue, as you guys saw in the video, where the chest wall was completely exposed. All of her musculature on the anterior side of her chest wall has been taken off. And that did not deter him from rehabilitating her. So I like to just recognize that going forward. And as far as what is done for my work and who I am, Pilates has always been a part of my professional life because I've seen the value in it from a perspective of its principles, not just the exercises. So my work is, I do work with breast cancer survivors. However, the bulk of my work is with women who are 45 and older, who I want to help guide them and help them lead healthier and more fulfilled lives. So what, in my opinion, one of the things that happens in Pilates is that if we're really staying true to the principles, if we're staying true to the guiding principles, breath, whole body movement, whole body commitment, then we can kind of take some of those sub principles and those movement principles and use those to help our clients achieve a goal, which to me is just being, self-efficacy, being able to do the things that you used to be able to do, or to improve the things that you currently are doing and take them to a next level. So for me, I think that if we can, as a community, remember that we're not just teaching exercises, we're teaching concepts, and that these concepts are universal concepts that go from the Pilates studio into life, then I think that that is something that could be a little bit more, we can have more of an effect on our clients in that way. So as far as I'm concerned, that's kind of how I use the Pilates method. I love the work. I love the exercises that come with it. I love the discovery. I love still being a student of it. I still love being a student of physical therapy as well. So I just think it's important for us to just remind ourselves of that. And I also want to just bring to fore this whole idea of no alphabet soup behind his name. Now, one of my early mentors told me that I need to have as many letters behind my name. They should be able to wrap around a card. And I literally have, lots of letters behind my name, but that plus $5 is going to get me a cup of coffee at Starbucks when it comes to cancer, right? So it doesn't mean anything really. But what I mean to say is that we want to recognize our achievements of having a national certification so that we all can have some recognition and we all have a standard to abide by as a community that tells the greater community at large, hey, we know what we're doing. So I think it's important for me to recognize that as well.
Yes. On the video, we saw a lot of customized Pilates work that Joseph provided for Eve Gentry. How do you incorporate the scapula and the thoracic organization into your own practice and the treatments?
Right. So for my own body and for treatments with anyone who has any kind of shoulder or back or upper back dysfunction, or even neck dysfunction, or even pelvic dysfunction for that matter, I do start to use shoulder blade slides, is what I call them. So we'll go through them in just a moment. But prior to me saying that, I want to let everybody know that breast cancer is a journey, right? And most people, most women will survive breast cancer. In fact, there's almost a 90% survival rate of a 5-year survival rate from breast cancer. And so there's still a lot of women who are still living out there and still want to be vivacious, and they want to feel sexy, and they want to feel seen, and they want to be challenged. So we as instructors need to recognize that, but also to come back to the journey part of it, it depends, the level of exercise depends on where the person is in the journey. And when we saw Eve, she is an athlete, right? So we need to recognize that he was rehabilitating an athlete. And I think Michelle speaks to that in the video at one point. But she's also likely towards the end of her recovery phase from the surgical procedure. So that being said, there's some gentle things that can be done at any time during someone's recovery, whether or not they're just starting to be able to exercise after the surgery and or those subsequent treatments such as radiation or chemotherapy, and also into endocrine therapies, which is, excuse me, typically after there's those other major treatments, which are surgery, radiation, and chemotherapy. So one of the things that we talked about regarding the guiding principles was breath. So with people who have cancer, there's this, we're kind of stressed out. People are kind of stressed out because, it's a life and death situation. So we know that breath can help to reduce the amount of stress that is in the body, because it helps to calm the sympathetic nervous system. So from that perspective, breath can be really helpful in helping the person just calm their system a little bit. So, and then the second thing that breath can do is help to mobilize the thoracic cage. And as you guys saw in the video, just from the surgical procedures, the scar tissue that can occur from the surgical procedures can reduce the ability of the rib cage to expand as you take an inhalation. So we all know about that Pilates breath, which is out to the side. We have that rib cage breath, right? So I've got my, and you guys can join with me if you'd like. If you don't have a TheraBand or a towel, you can just use your hands and put them at your sides on your rib cage. And so we're just going to start to practice. You can do this in sitting, you can do it in standing, you can do it lying down if that feels better for you. And we're going to start to inhale into I'm going to inhale into my hands. I'm inhaling to expand my rib cage. And then I'm going to exhale. And now I'm going to just continue to inhale and exhale. But from a biomechanical perspective, what we're working on here is called that bucket handle movement of the rib cage, which says that the ribs move out to the side and up as you inhale. And then they close and come down and in as you exhale. And as we're continuing to do that, I'd like you to continue to do that a few more times. Let's go for 6 more. Inhaling. And then exhaling. And you guys continue on your own. If the person is not able to put their hands on their rib cage, you can always use a towel or a TheraBand, wrap it around the lower part of the rib cage, and just have the person hold the TheraBand. Several of you likely know what this exercise is, but you're going to expand into the rib cage. I'm sorry, into the band. And then you'll exhale. And we're going to go for 2 more here. And exhaling. And I'll do 1 more inhale. And I'll do an exhale. So that is going to help to start to mobilize the rib cage and the thoracic wall. So that's a nice little starter place for everyone to go to. Anything else?
I have a question, Deirdre. Could you address the fascial scarring in this area, and what kind of movements, like how aggressive should we be in like opening the pecs up? And
great question. Thank you. So the surgical team is going to be in charge of how much motion the person or the woman is able to have after the surgery. The goal obviously is to have as much range of motion as possible. It also depends on the type of surgery that is performed. We saw a radical mastectomy, which means that the entire breast tissue was taken off at that time. Radical mastectomies look different now than they did at that time. However, there is a significant amount of tissue that is being taken off. There's more of a breast conserving surgery that occurs, meaning that they just take out the lump most of the time, and then they preserve as much of the normal breast tissue as possible. That all being said, there is still scarring that occurs. So when we start to we do want to open the chest. However, we need to have the guidance from the physical therapist or the surgical team to let us know when that can happen. Because if there is, say for instance, an implant that's put in, there's a plastic surgeon that is involved, they may have limitations as to how much opening that they want to have occur. But that all being said, one of the things that you can start to do with the scar tissue to mobilize it is to just start to lift and lower. We can start to use shoulder blade movements to help us with that. So what happens with the scar tissue is that from a fascial perspective, those fascial planes, they get stuck on each other and they don't move. So one of the things, again, with breathing, we can start to move those fascial planes a little bit, but we can also start to use our shoulder blades and start to re-educate the shoulder girdle a little bit without using this load of the arm in order to do that. So one of the things that we can start to think about is, I'm going to just use my guy here, and this is a shoulder girdle. And so we're going to just be working on elevation, depression, and we're going to go from elevation forward and up, and then we're going to rotate back and down. We're just going to do circles forward and up and back and down, and we'll reverse those. And then we'll be going into shoulder blade adduction and abduction in order to allow the shoulder blade to glide on the thoracic cage as it normally would, with us trying to get our hands over our head. So the goal here with life is, for the upper extremity is can I get my hand over my head? Can I put my bra on? Can I, comb my hair, or can I wash my hair? All of those things are functional activities that need to be done. So from a perspective of, regardless of where they are in their recovery, someone should be able to just move their shoulder blades. And so we can just do a few of those now. So we'll start here with inhaling to lift the shoulders into the ears with shoulder elevation as you inhale. And then you'll exhale to let them fall. You're not going to pull them down, because I have a whole thing about pulling them down. If you haven't seen my movement science workshop on the shoulder, this whole pulling down of the shoulder blade is like the bane of my existence, but that's another course. So inhaling up, and then exhale, just let them fall. And inhale up, and exhale, let them fall. We'll do 3 more. Inhale up, and exhale, fall. And we'll do 2 more. Inhale up, and exhale, fall. We'll do 1 more. Inhale up, and we'll exhale, let them fall. So we'll start to do circles forward and up. So inhale to let the shoulders come forward and up, and then exhale to let them rotate back and down. So again, no squeezing. We're just moving the shoulder blades along the thoracic cage. And I want you guys, we're going to do 5 more. I want you guys who are tapping in to just see if you can feel your shoulder blades gliding on your rib cage in the back. And we're going to go for 2 more here. Inhaling up and forward, exhale back and down, and we'll do 1 more time. Inhale up and forward. We'll exhale back and down. We'll hold here. We're going to reverse it. Inhale back and up. Exhale forward, down. Inhale back and up. Exhale forward, down. Inhale back up. Exhale forward, down. We'll do 2 more. Inhale forward, back up. Exhale forward, down. And we'll do 1 more. Inhale back and up. Exhale forward and down. So the next exercise we'll do is going to be geared towards starting to let the shoulder blades come into adduction and abduction. So I like to do it with my hands in this goalpost position. The elbows are going to be at the same height as the shoulders, and we're just going to inhale to open the arms out to the side, and we're just going to gently open. So we're not squeezing, we're just reaching the elbows to the side walls, and then we're going to bring them back to the start position on the exhale. So we're going to inhale to open, finding the breath and opening the rib cage and feeling the smile across the chest without squeezing again. And then we'll exhale to bring it back. We'll do 2 more. Inhale to open, and then we'll exhale to come back. And we'll do 1 more time. Inhale to open, and you'll exhale to come back, and then you'll return down. So those are just some nice, gentle exercises that we can start to introduce to people and to women to help the shoulder girdle start to move along the rib cage, and to help to reduce the scarring that can occur from the surgical procedure, and also from radiation. So there's this thing that's called radiation fibrosis that can occur after the tissue is irradiated. So radiation is designed to sterilize the tissue that's still present in the breast. And because of that sterilization and because of the radiation, the tissue that's left can become fibrous. And so one of the things that because of that, it can start to the tissue can start to adhere, very much the same way that we saw in Eve's video. So we want to prevent as much of that radiation fibrosis as possible with movement. So that's that.
Deirdre, I know from being with you in the dissection labs, different tables, and being at Pilates on tour, I know that that sometimes I've seen you in a sleeve for lymphedema, and so would you speak about that and how you
Yes.
help your clients navigate the difficulties of lymphedema?
Thank you for that. So if you guys haven't noticed, I'll show you here. You can probably see it if I stand up. I have a mild form of lymphedema. And lymphedema can occur, for those of you who don't know what that is, lymphedema is a potential complication from the treatments of breast cancer. So one of the treatments is because I had a surgery and they took the lymph nodes out of my armpit here, which helps to drain the fluid, and it's also part of the immune system, by the way. The lymph system is a huge part of the immune system. It helps to drain the fluid out of my arm. Because they took all of those lymph nodes, I have lymphedema because there's not a sufficient draining system. However, well, I don't want to go there. We'll talk about that potentially later. But one of the things that occurs, this is a complication that can occur with breast cancer treatments. And so women who have had radiation, and women who have had, it could be any surgery, that even a sentinel node biopsy can potentially start a lymphedema event. So lymphedema just can come on at any time. So one of the things that we want to be careful of when we are working with clients who are recovering from breast cancer is, we want to know, have they had a lymph node dissection, meaning have they had several lymph nodes taken out? So I want to back up a little bit. A sentinel node biopsy is what happens when they take the nodes. They take 1 to 3 nodes out of your axillary lymph node area, just to see, and they put dye, and they want to track that dye to those lymph nodes to make sure that those lymph nodes don't have any cancerous tissue or cells within them. So that's the difference between a sentinel node biopsy and a full axillary lymph node dissection, which is what I had, which took out 23 lymph nodes. So back to the exercise, when you are working with a client who is recovering from breast cancer, we do want to challenge them, because again, our goal is self-efficacy, independence, and being a badass, really. So, but we want to also be mindful that if we use too much weight or too much resistance for the upper extremity, that could flare or actually cause a lymphedema event to occur. Lymphedema, they don't know. There's risk factors. You can be going on with your life for several years without any kind of lymphedema that has occurred in your arm after you've had your treatments. But then one day you are playing baseball or something like that, and then boom, you have lymphedema. So there is no real cause and effect. You just have risk factors that make you take you at a higher risk to get lymphedema if you, say, for instance, have a axillary lymph node dissection like I had. So the bottom line is that we want to use a moderate level of resistance, probably around somewhere, but nowhere more than about 10 pounds, I would say, is a good number for you to be thinking about to prevent, excuse me, to prevent a flare, because there's too much weight that's being used in the upper extremity. So I hope that answered your question. It was a little long-winded, but hopefully it answered it.
It's fabulous and fascinating. Would you show us some of the moves that you do with the equipment, some of the exercise
Sure,
sequences that you
sure.
recommend for that?
Yeah, so I am going to, let me get all my stuff out of the way. So we kind of started talking about moving the shoulder blades. And so one of the great things that we can do with the push through bar, and I'm going to just turn my camera this direction in theory. Can you guys see there? Yeah, there we go. Okay. So, and I've got one blue spring on here. So instead of doing, say for instance, the seated push through in the full variation where the legs are long, I typically like to have the person start with them straddling the bench, because, you know, especially when you're introducing the movement to someone, you take the legs, the long legs out of the picture, and you fixate the femur, and then the pelvis can roll on the femur if you decide that you want to go into a cat or a variation of the kneeling cat. So what we're going to start with, though, is just doing some shoulder blade motions with the push through bar. And so I'm going to start facing forward. And if you are height challenged, or if your client is height challenged, you can always put some blocks underneath their feet so that they can be touching something that is firm on the floor. And so I'm going to get myself so that I'm right on top of my sits bones, and I'm in a pelvic neutral position. So I'm going to take my hands, I'll put my little bit more emphasis on the pinky sides of my hands, because I want to have this idea of lateral rotation of the arm, because when you get your arm up overhead, there's this lateral rotation that has to occur in the shoulder girdle in order to get the arm overhead in a efficient manner. So I'm going to just give that idea, and it also starts to get into the anterior oblique sling system. So a little bit more emphasis on the lateral sides of my hands, and I'm going to take my elbows and press them down, point them down, and then I'll push forward. And then I'm just going to take my elbows and point them down instead of going out to the side, because this is, if I was to take my hands off of the bar, I would be in internal rotation when I really want to be in external rotation. So I'm going to pull the bar down, press it forward, and then I'll slowly resist the bar as it comes up, and then I'll push the bar up, and then I'll allow that pinky side of the hand to press into the bar a little bit as I take the shoulder up, as I extend my arms up into flexion. And I'm going to start to shrug my shoulders. It's okay to shrug the shoulders, because remember, we want to have the shoulders be able to elevate a little bit, because that's what's required in order for us to get our arms overhead. Then I'm just going to let my shoulders just come back to the start position. I'm not going to pull them down, and then I'll push and pull the bar down. And then I'll just keep going through that series of allowing the shoulder blades to elevate. They'll come down into a neutral position, and then they'll come into a depression, and then I'll push forward. So you can do that several times. It's a really nice way to start to re-educate motion and a pseudo closed chained position, for those of you who know what that means. So then I can also turn and face forward, and then I'll be also starting to do abduction and adduction of the shoulder girdle, of the shoulder blade, should I say. So I'm going to push up, and then I'll exhale, pull the bar down, push the bar away. And so in this position, my shoulder blade is in a kind of a downward rotated position. And then as I start to push the bar up, it's in an upwardly rotated position. Okay, so I'll pull down, I'll push the bar away from me, and it's in a relative downward rotated position. And then I'm going to take it back up, and it'll be in a relative upward rotation position. Okay, so these are really nice exercises to just start to re-educate just gentle shoulder motion. And as you can see, I just have a blue spring on. You can have a yellow spring on if that's appropriate for the person. You can also hold the position where the arm is in that, where the bar is down in its lowest position. And then you can start to push into the bar to allow the shoulder blade to move out into abduction and then adduction, abduction and adduction. So just moving the shoulder blade on the thoracic cage. Okay, and then I'll take it back up. So that's one part of the series, is the scapular series. And then all of that can move into several other different motions. And one of the things that I really like to do is, I got this one from, this is not mine, okay, but I got this one from Alexander Bolander from Polestar Pilates in Germany. And he calls it the 8 motions of the spine. But what I really like about it is that it allows the shoulder blades to really move on the thoracic cage with the coupling motions of the whole spine. And it allows there to be this unity. So I'm gonna just go into my quadruped position. And again, some of you may have seen this from me before. So I'm going into quadruped, and while in quadruped, let me make sure my earphones are not gonna die. Okay, so while I'm in quadruped, I'm gonna get myself organized here so that I'm in a neutral position, head is looking down, and I've got a little bit more weight towards the pinky sides of the hands. One of the things that I tell my clients to do is feel as though they're almost twisting the top of a pickle jar, like this, so that I can activate that external rotation moment in the shoulder joint or the glenohumeral joint. So I'm going to inhale here to prepare. And then as I exhale, I'm going to start to round the spine, look down through my knees. And when I round the spine and look down through my knees, I notice that my shoulder blades go apart from each other, or they abduct. Okay, and then I'm going to go into extension. So I'll start to lengthen my spine. I'll look forward. I'll bring my chest through my shoulders. And then as I'm in this extended position, my shoulder blades are adducting towards each other. And then I'm going to come back to the start position. So then I'll bring my feet together, my knees together. I'll lift my feet off. I'm going to twist to one side. So now I'm doing side bend. So my left shoulder is now doing a version of shoulder depression. And then my right side is doing a little shoulder elevation. And then I'm going to do the same thing going to my right, where my right shoulder blade is doing depression, my left is doing a little elevation. I'm coming back to my start position, bring my feet down, I'll open my feet and knees apart from each other. So my left hand is going to stay planted. I'll reach my right hand out to the side. So if you notice, I'm going to be reaching with my thumb leading the way. My hand is not going to, my palm is not going to be down towards the floor. The thumb is going to be up. So I'll take the thumb up. I'll look at my hand as I do my rotation, and then I'll dive and thread the needle, sit back. So here in this position, both shoulder blades are in an abducted position. And then I'm going to come back to the start. And then when I reach my left hand out to the side and up, they're more in an adducted position as it relates to rotation of the spine. And then I'll stretch and I'll rotate. And then I'll come back to the start position. All right, so I'm just gonna move through it without all the talk. So you're gonna inhale to prepare, you're gonna exhale, curl, look down through your knees. And your inhale, take the chest forward and up. You'll exhale to come back to the start position, bring both your feet and knees together, lift your feet off of the floor. Start to sweep your legs over to the left, look over your shoulder for your feet. Sweep both your feet over to the right, look over your shoulder for your feet, come back to the start position, open your feet and knees apart, reach your right hand out to the side, thumb leads the way, pressing down on your left hand to help you with the rotation. Exhale, press and come through, rotate to your left, and then you'll come back to the start. We'll do one more time on the left side, reaching out to the side and up, pressing down with your standing hand, which is your right. You'll dive under, reach towards me, and then you're going to come back to your start position and you'll rest. Okay, I think that's a pretty good series.
Lovely theory.
That's, yeah, yeah, yeah. Deirdre, would you segue into your a different perspective now, speaking about your practice as a in women's health, and also the even the broader perspective of Pilates applications for people of color?
So my specialty with women, I just want to say that I'm not a women's health specialist. I'm just a woman. And I know what it's like, and I'm postmenopausal because I had to, because of the treatments regarding my breast cancer. So for me, my breast cancer was what they call estrogen and progesterone receptor positive, which means that estrogen's like kryptonite for me. And so is progesterone. So that means that the tumor grows in the presence of estrogen and progesterone. So for me, I chose, I didn't have to, I chose to have my ovaries removed, which means that I went right into menopause. So from that perspective, I understand what it's like to be a woman going through that journey, maybe a little bit earlier than some would have in their lives. So from the perspective of working with women who, my goals are to impact women and give them more choices as far as their ability to move, and them also having the choice of being able to access exercise that's easy and that's doable, that can also help them stay present and also help them move towards a journey that they may be having towards wanting to have a even healthier lifestyle. So my lifestyle, I changed a lot of my lifestyle during my breast cancer journey, and it was incremental, but it has been a huge compound effect for me over the years, and it's helped me really stay in the place that I am right now and feeling my power. So that's how I try to help women in general. As far as speaking to people of color, there's a lot going on in the world regarding this. And so one of the things that I think is important that we have not done enough in the Pilates community is doing a little bit more outreach to people of color. I think that I'm really glad to hear that there's much more change. There's more and more changes that are occurring quite rapidly, given the current state of affairs. And I'm really happy to hear about that. One of those things that I recently heard about was that there's 2 appointments onto the Pilates Method Alliance board. I know that there were some missteps from the Pilates Method Alliance as we were going into the current racial divide that we have been trying to manage. And I think that what's happening now by appointing Nikki Taylor and Stella, it's going to come to me. Forgive me, Stella. Hold on just one second. Stella Lampkin, Stella Lampkin to the board, I think is an important step for the Pilates community. So because of that, I think that we can start to talk, and they have the potential perspective to have people understand in our community, in the Pilates community, what the social determinants for health is, right? So what do I mean by that? Health is only really about, healthcare is only about 20% of this whole idea of the social determinants of health, which includes several different factors. But one of them is nutrition, right? So if you are in a situation where you're living in a food desert and there's a liquor store and a convenience store and there's several fast food places for you to get nutrition, your nutrition is going to be at a deficit significantly. Another one would be this whole idea of environment. Our people of color are typically, in a lot of cases, living with multiple people in a one area, in one apartment or in a house. And so there's several people within that. And is there this idea of not being able to have an environment that allows for freedom of movement because they just might be confined given the fact that they're sharing space with others. Those are just two that I can think of off the top of my head. But the point being is that I think from a Pilates perspective, one of the things that we can do as a community is start to have this outreach and start to provide maybe some sort of free class or some sort of low cost class just to a general community of color to help movement occur, right? And so Joseph wanted us to have everybody to do Pilates. And I know that, there's this whole idea that Pilates is so expensive. And I do believe that we should get paid for what we do. I'm a businesswoman. I'm not, a philanthropist. I do believe that we should get paid for what we do. However, I do think that we can start to incorporate ways to be a little bit more inclusive of not just people of color, but everyone. And we have to do it in ways that's going to be smart for us as business people and also for the community in general. Let's see.
We have a number of questions.
Oh,
and
great.
because your presentations are just so stimulating. Madeline, would you take it away?
Yes, some really interesting questions. But here's a beautiful comment from Carol Davis, who all three of us adore. She writes, "So good to see the three of you here together. I love Deidra's approach to getting movement in the myofascia at such a basic focused level. Diedra reminds me of how much I enjoyed working with Polestar Pilates therapists in Miami. When we released the fascia first with Barnes myofascial release, gentle pressure and elongation to melt the gel and allow the tissue to resume its lengthened position, the motion was facilitated. Both of these treatments help bring much needed fluid to the area and reduce scarring." So she brings up fluid, which is really interesting because I'm going to jump around a little bit. I'm not going to actually go in order, but we have a couple of questions about fluids. So Barry Craig asked, "Can you tell us what is the effect on the fluids in these tissues that is caused by radiation? Has this been researched at all that you know? I'm especially interested in targeting fluids within the fascial tissues. Thanks."
That's a good question. As far as fascial tissue fluid and the research around radiation therapy, I don't know of any. I can't say, I don't want to answer that question in the sense that I am an authority on this, because I don't know that there is research out there on the fluids regarding radiation fibrosis. What happens with radiation fibrosis is that there is a scarring of the tissue. There is the fluid that is taken out of the tissue. Regarding fascial perspective, I think that the fascia, that there's so much new research around fascia and the fluids that are released, and I'm not sure that there has been a direct correlation between radiation and that fluid exchange or lack thereof with fascia specifically. But I can make the assumption that that is likely one of the things that is happening, that there's a reduction in the fluid in the fascial system, such that because of the radiation and the prolonged exposure over time. Because once you have the radiation, it is a compound effect. So you do it over 30 sessions and it's a compound effect that occurs. And so that radiation lasts within the body for quite some time. So, so it's a really good question. And I think it's an important piece, as Carol had mentioned earlier, that we do keep the fluids. Motion is lotion, as we have all heard. So I think it's a great idea to continue to move in that way. But if you hear of any research, please let me know.
Michael Hall asks, do you think having correct shoulder blade position in sync with the Pilates breath switches off the stress hormone cortisol and the effects of radiation. It says, quote, pouring water on the fire.
Well, I think that that's interesting. So thank you for the question, Michael. I think that when you're doing the breath specifically, I know that that has an impact on cortisol levels by reducing the sympathetic load that is happening. So it helps to reduce that fight or flight. It helps to reduce the stress that comes with going through treatments, with having the diagnosis, with living with, as a survivor. So that all can help to reduce, the breathing itself can help to reduce that sympathetic load that's occurring. And so as far as the shoulder blades moving on top of the rib cage, I never thought of that either. I think that any kind of motion, again, is going to stimulate the motion of the shoulder blades on a, excuse me, on a thoracic cage is going to help to stimulate the motion and help to decrease, and it will potentially actually help to improve the thoracic cage's capacity to breathe and to increase the vital capacity in the lungs as you are taking that breath in and out. So from a perspective of the biomechanics, I think that it could totally work. And I think that from the idea of breathing through your belly and having deep breaths, I think is an important part for us to understand to help to down regulate that sympathetic nervous system or that fight or flight.
So we're going to stick with the shoulder blades. A very good question from Michael Hall. Do you think the shoulder blades play a key role in stimulating the thymus gland?
Interesting.
Mm-hmm.
I never thought about that. So thank you for that, Michael. That's something that I have not thought about, but I will look into that. And if you leave us your information, I'll get back to you on it. That's a great question.
So when you're breathing, Deidra, as you're taking that breath in and your scapula are moving with the breath and your rib cage is expanding, of course the lungs are expanding and that's stimulating the heart. So you could see where the thymus gland, through the flow and the vibration of the breath, how that could send kind of a waving, sensation.
Sure.
The thymus, that's how I would think about it.
Yeah.
Great. Wonderful. Christine asked, Deirdre, how long after the surgery do you recommend doing exercises you just showed?
Do you, maybe if you can clarify the question, meaning how long after the surgery do we start the exercises, or how long do we do them in general?
I think after the surgery, how long after surgery would you start doing these exercises?
The ones that we were first doing, I think are really great exercises to start to introduce movement as soon as it's cleared by the physician or the physical therapist. This is something, again, if someone is having some sort of surgery, the surgeon does want them to start to move as soon as possible. However, you want to make sure that you get the clearance from the physician or the physical therapist. And that typically, I want to say, is, in my experience, has been about 2 to 3 weeks after the surgery. But again, that's something that you're going to have to. So part of our job as Pilates instructors is to be a part of a team, right? This is a team approach. So the captain of the team is the patient, right? Or the client. So you want to make sure that you are corresponding with all of the people who are in her team to make sure that you're giving her the best outcome as possible. So my advice to you is to make sure that you get the physical therapist's telephone number, or you get the surgeon's telephone number, or you email them and say, hey, I've gotten your client's wanting to start to work with me again. Is there any restrictions that I need to be aware of as far as her movement is concerned? That's the best way for you to answer, for me to answer that question, and for you to make sure that you're doing no harm.
Okay, we have Virginia Hibbs asked, how would this be modified for osteoporotic kyphosis? I think she's talking about maybe your CAT series.
Right. So if you're doing the for kyphosis, right? We want to, if you're saying that because the person has a lot of kyphosis, I wouldn't take them into the flexion position. And if they have osteoporosis, I wouldn't take them into the flexion position either. So I would start here in a neutral position, and then I would go with the chest going forward and through the shoulders. Okay, so that's one way that you can do it. The side bending variations, right? So you can, with osteoporosis, if you notice here, my spine is relatively neutral in this position. And then as I go into side bend, I am going to have a little bit of side bend. So osteoporosis can go mid-range side bending. And you can also side bend to the other side in the mid-range. So you're not going to go into the extremes, right? But you're going to go into like in that mid-range of side bending, and that's totally fine. One of the other reasons why it's fine in this position is because my spine is relatively unloaded. If I was in an upright position, my spine is loaded. So that's something that's a little bit different. Regarding the rotation variation, you can still do rotation and extension. Rotation extension is okay in the mid-range. So you're not going to go into the full range. You can go into mid-range, and you can still go into a variation of the flexion where you're not maybe sitting back and rounding the spine, but you're actually just reaching through the shoulder and you're going in through the mid-range. And then you'll come back, and I'll show you on this side again. So you'll reach out to the side, and you won't go into the full range of motion. You'll stay in that mid-range, and then you'll rotate so that you're in a relatively neutral position. If you look at my spine, it's not rounded. It's staying in a relatively neutral position. Hopefully that answered that question.
Very good. So I think that's pretty much all the questions that we have here. Michael Hall, our thymus question, this would be interesting to research or to read about, is radiation blocks the cerebral spinal fluid, which bathes the central nervous system.
Mm. Is that a question or a statement?
That's all he wrote. I think after our question about it wasn't really a question, it was just a comment, but I think after we were talking about stimulating the thymus gland, maybe perhaps it's related to that, but anyway.
Okay. Yeah.
Very
Michael, I'd love to have more of a discussion with you on your interests. So please reach out to me.
Yeah, so Barry's commenting, this is wonderful. Using the latissimus dorsi to depress the humeral head upon personal palpation reveals to me that the result on the thymus gland is that it opens it up and enhances the flow arterial to the gland. Just check this out because I was curious about Michael's question. Nice thinking, Michael. Thank you.
Absolutely. Thank you. Thank you both.
Yeah. Okay.
We're at the top of the hour now. So Deirdre, do you have summary comments? And then we'll look at the slide that shows people how they can get in touch with you.
Well, I'm glad everyone, thank you so much for coming and hanging out with us today, this morning. And, this has been a real great opportunity for me to be able to talk about this work to people like you so that you can help the greater community at large. 1 in 8 women will be diagnosed every year. That's 13% of the female population will be diagnosed every year. So anything that you can do to help women optimize their recovery and help them get back to what they were doing prior to their diagnosis and helping them move forward in their life, I am so grateful for, and I know that they will be grateful for as well. So thanks so much for coming.
Thank you. Now we can't hear Elizabeth. So Hillary, you're going to show the slide.
So please, if you have any questions, my information is here on this last slide. You can always email me. Please get in touch with me at drdeidra@monarchwellnessinc.com. I am also on Facebook as Dr. Diedra Manns. I am also on Instagram as Dr. Deidra, and you can also look at my Facebook business page, which is at Monarch Wellness Inc. So please feel free to contact me, reach out, and I look forward to seeing you guys sometime in the near future. Thanks so much, Elizabeth and Madeline. It was great.
Wonderful to have you.
Thank you, thank you, thank you.
So there, I think we can keep, Elizabeth, we can't hear you. So I don't know if she can hear me, but yeah. So we have a few more minutes if we want to, because I don't know if people are staying on, but we have a couple more questions that came in at the very end.
Okay.
Lorna Rosa asked, do you recommend using lymphedema support for upper extremity exercise, even if they don't have lymphedema?
No, if they don't have lymphedema, no, there's not a reason for them to use the upper extremity support. If they do have lymphedema, they should use the their upper extremity support if it's at a which is called a sleeve, a compression device. And especially if you're going to be doing an extended workout with them, you do want to use the compression device. Also, I didn't mention this to the larger group. For lymphedema, one of the things that has been found is doing rebound therapy, i.e. jump board. So get your jump board in there a little bit to start to allow the lymph system to flow a little bit more. So hopefully that helps.
Great reminder about the jump board. Yeah.
Mm-hmm.
Okay. Everyone's just saying thank you. I learned so much. And Tanya Scott says, I'm blessed to work with you. So maybe you know her.
I do. Hey, Tanya.
Inspiration. Yeah.
Thank
Great.
you.
All right. Thanks, Deirdre.
Okay. Thanks so much, guys.
We'll be in touch. We've got work to do.
Right. We do. All right. Thanks so much, everyone.
Okay,
Take
bye-bye.
care. Bye.